In RA, we did not use MRI systematically, but we know that MRI inflammatory findings is of prognostic value. We know that synovitis, and in particular MRI-detected bone marrow edema, predict radiographic progression, and that's not only in patients with active RA, but also in patients in remission. We know that patients in remission, still 20 to 30% of the patients progress erosively. Yeah. That was why we know the patient progress, and that was why we wanted to investigate whether the use of systematic MRI targeting MRI remission defined as bone marrow edema in our study on top of current treatment strategies would lead to improved clinical and radiographic outcomes. And in our study, we looked at two predefined primary outcomes. We looked at the proportion of patients with no erosive progression at 2 years, and we looked at the proportion of patients achieving DAS28 CRP remission. We also looked at several secondary, predefined secondary outcomes. We looked at function, quality of life, other MRI parameters, and various remission criteria. Yeah. We included patients in what we defined as clinical remission, being a DAS28 less than 3.2 and no clinically swollen joints. The patients were randomized to a conventional treatment strategy or a conventional treatment strategy and MRI. We escalated treatment in both treatment arms if DAS28 showed sign of disease activity at DAS28 above 3.2 and at least one clinically swollen joint. But also in the MRI-guided group, MRI was performed ahead of every visit. We saw the patients every 4 months, and they were evaluated for bone marrow edema absence presence. So if we found bone marrow edema on that MRI in the MRI-guided treatment group, treatment was also escalated, and that would be respective of the disease activity score. The main outcomes we looked, as I said, at DAS28 remission and no radiographic progression. We could not show a difference between the treatment arms in achieving the primary outcomes, but several of the secondary outcomes favored the MRI-guided group. More patients in the MRI-guided group achieved, you can say, deeper remission, achieved ACR Boolean remission. It was 50% versus 30%. And we also saw that the MRI-guided group had better improvement in swollen joint count and their overall assessment of disease activity, and a better improvement in function if we looked at the HAQ score. And in addition, if we looked at the MRI findings, we saw an improvement in the inflammatory load, significantly different from the conventional group. We need these kind of studies to see how we should use MRI, if we should implement MRI. And based on the result of this study, we can say in a remission cohort like this, it is not justified to implement MRI, looking at our primary endpoints being DAS28 CRP remission and no radiographic progression. So, but it could be very, very interesting to look at our secondary endpoints in the future, because what does it mean that the patients have achieved deeper remission, they have a very low inflammatory load? Will it benefit the patients in the long term? And we have actually a few years ago, or 3 years ago, already made a follow-up study called Imagine More, where we look. It's an observational study where we see the patients at 3, 4, and 5, and 10 years after they were included in the Imagine RA study, to see the long-term consequences of this 2-year MRI-guided treat to target strategy.